เข้าสู่ IAOC Series นะคะซึ่งครั้งนี้เป็นในเรื่องของ IAEA Expert Mission นะคะ Strengthening Optimization in Radiological Practice นะคะแล้วก็เช่นเคยนะคะเราได้รับเกียรติจาก Expert จาก IAEA นะคะดร. L Brady จาก Cincinnati Children's Hospital นะคะซึ่งครั้งนี้เนี่ยก็คือเป็นอาทิตย์ที่10ละเรามีทั้งหมด12ครั้งเรามาเกือบจบแล้วนะคะครั้งนี้เป็นครั้งที่10แล้วอาทิตย์นี้เนี่ยเราจะมาพูดถึงในเรื่องของ Imaging Quality Metric ของ Mammogram นะคะแต่หลังจากที่อาทิตย์ที่แล้วเนี่ยเราส่งคำถามไปให้คุณแซมนะคะว่าเรามีคำถามเกี่ยวกับเรื่องของการ shielding ใน radiology เนี่ยว่าส่วนไหนต้องชิลส่วนไหนไม่ต้องชิลหรือเดี๋ยวนี้เราไม่ต้องชิลแล้วเนื่องจากไกด์ไลน์ใหม่ที่ออกมานะคะซึ่งคุณแซมก็ใจดีมากนะคะที่จะเลคเชอร์ให้เราฟัง1ชั่วโมงเลยนะคะ1เซสชันในเรื่อง shielding ทั้งหมดของ radiology นะคะก็ Good evening, Sam. Welcome back again on the IAEA Expert Mission. And this week is week 10 that we're supposed to talk about the mammogram stuff. But after last week, I have a questions for you about the shielding in radiology. Do we still need to do shielding in CT, like a gonad shielding, thyroid shield, or breast shield, or something? So the plan is you are going to give us a talk about the shielding, every shielding in radiology, what should we do or do not do, and the basic principle and concept on that things. And the next hour, we are going to talk about the mammogram, like image quality, metrics, and also optimization. So welcome back again.
Thank you. I couldn't unmute myself.
Okay.
You didn't want me to talk, did you? Well, thank you, Tanya. Thank you for the introduction. Once again, I'm glad to be back for everyone that's here with us live. And yes, just like Tanya mentioned, at the very end of last week, there was the question about patient shielding. So of course, last week, I guess for the last 2 weeks, we've been talking radiography. We've been talking generally DR and CR imaging. And so the question came up, what about shielding, patient shielding? So there's a lot of different ways we shield our patients. And I wanted to talk a little bit about that. So I'm going to answer the question that Tanya asked about gonadal shielding. But when I started putting this talk together, I also decided, gonadal shielding is very specific, of course, to DRCR, but what about shielding that we use in dental and mammography and CT? And so I've decided to create one lecture based specifically on answering the question, what should we do about shielding? And we'll go through all of the modalities and all of the different ways that you can shield in each of these modalities. So it's going to be a very complete discussion. Hopefully we'll have lots of good questions and we can have a good conversation at the end. So I'm going to talk to you, I'm going to show you the science behind the use of these shields. So I'm talking about patient shielding. I just want to stress that a couple of times. I'm not talking about staff shielding. So people that work in fluoroscopy, you put your aprons on, your thyroid shields, you might even wear your glasses. I'm not talking about that. That's stuff that is really good. That's very important for you as a staff member. So this is about a patient that comes in and do we put shielding on them when we're doing imaging? And then, like I said, I definitely will, I promise, I am going to talk about gonadal shielding. So before we start, I'm going to jump to the end. I'm going to give you the conclusion. I'm going to give you 2 statements. And then I'm going to spend the rest of the hour trying to justify these 2 statements. The first statement is, generally speaking, patient shielding is ineffective and unnecessary. And the second statement I'm going to make is, once again, generally speaking, when patient shields do not affect image quality, they can be used to help patients. Oftentimes, we use them when a patient's nervous about radiation or when they request personal shielding. There's nothing wrong with it as long as it doesn't interfere with the imaging. And in pediatrics, actually putting a heavy lead apron on them will actually hold them still and they won't move as much. So there are some positives to it. But for using aprons, these lead aprons, for shielding purposes, I hope to demonstrate to you why they're not that necessary anymore. So there are always exceptions to every rule, and I hope to demonstrate those as we go through. So you may already be thinking in the back of your mind, thinking, wait a minute, I've seen this be very helpful. And so we'll talk about that when we get to those examples. So because this was the original question, I'm going to start with gonadal shielding. So let's give a little bit of perspective. When did gonadal shielding, when was it first introduced? So in the US, unfortunately, I don't know the Thai history, but in the US, gonadal shielding began to be used in the 1950s. The main purpose, the whole reason that they started placing lead shields on top of the gonads for people when they were receiving an x-ray was to prevent heritable genetic effects from radiation exposure, excuse me. The concern was that if exposing the gonads, there would be some kind of mutagenic effect, and then that would be passed on through the reproductive process to the progeny. And so we didn't want to affect the gonads and thus, of course, the gametes, the sperm and the egg, so that we would have issues, genetic issues in our offspring. That was the purpose, that was the thought process behind using gonadal shielding back in the 1950s. You have to understand, though, putting this all into context, back in the 1950s, this was only a couple years after the atomic bombs were released in Japan. And so our understanding of radiation effects and risk was primarily, of course, from the Hiroshima and Nagasaki bombs, but they were based on deterministic effects. A couple of years, about 5 years out from the dropping of these two atomic weapons, we didn't have a lot of data to start projecting future cancers. But we definitely saw skin burns. We saw a lot of those types of effects. And so we immediately from the beginning knew that radiation would damage the body. We just didn't know to what extent it would be long lasting or it could be passed on through the reproductive process. As I mentioned, our understanding of stochastic effects or cancer was very, very early, very nascent at that time. So also, looking at this historically, what were the radiation doses? What was the level of radiation we used in planar radiography back in the 1950s? So for an adult anterior posterior radiograph of the abdomen, just a single view, they were about 11.5 milligray. Now, if you did an AP of the pelvis, it was about 9.5. If it was a kid, of course, it was smaller because the patient was smaller, but it was about 1.5, 1.4 milligray. So fast forward to more recent studies. So a study that came out of Europe, their value was 0.8 milligray for an AP radiograph of the abdomen of an adult. So substantial reduction, almost over a tenfold reduction in radiation dose from the 1950s to now for the exact same view of the exact same abdomen. And then if you look at the Thai data that we had looked at from the very beginning, the data that you guys have collected, you guys are about 2.8 milligray for an AP abdomen, an adult AP abdomen. All right, so like I mentioned, doses have come down considerably, over 94% dose reduction in that time span, which as you would expect, right? Newer technology has come on, a different way of imaging. We're not using film anymore. We're using digital systems. We would just expect the radiation dose to come down. So with that comes a new way of thinking. If the shielding was used at a time when we used a lot of dose, higher dose, and also, of course, it was based on a different type of thinking that we were protecting against progeny, effects of heritable effects instead of cancer effects. Do we still need to use shielding? So a couple of years ago, there was a couple of papers that came out. A gentleman that I work with here at Cincinnati Children's, he and a couple of his colleagues wrote a paper saying that we don't need to use gonadal shielding. And from that time forward, myself and a handful of other people started looking at this, and a group within the AAPM came up with a position statement. I was actually part of this when they wrote it. It's, I think, about 2 years old now. And in part, it states patient shielding may jeopardize the benefits of undergoing radiological imaging. Because of these risks and the minimal to non-existent benefit associated with gonadal shielding, AAPM recommends that the use of gonadal shielding should be discontinued. So there's two things in here I highlighted in color. The first is the use of shielding doesn't really provide benefit anymore or at all. And we'll talk about that in a minute. So if there's no benefit, the benefit to risk ratio, let's talk risk. I will show you in a couple of slides how there are risks for actually placing the gonadal shielding on the patient and imaging. There is the potential that that shielding could actually cause more radiation dose to our patient. So let's talk about that. So because that benefit to risk ratio, whenever we talk about radiation, if there's a greater benefit from acquiring an image or using radiation, then we always say there's the benefit outweighs the risk. In the occasion when the risk to benefit ratio is flipped, obviously we would say, no, we don't want to use this procedure anymore. So we're very familiar with the benefit to risk ratio. We do this every day in radiology when our doctors are putting together their protocoling and they're setting up the patient scheduling. And there's always that question, is there benefit to these images being ordered? And whenever there's not, in a daily basis, we say, no, we're not going to do this imaging. So that mindset, I hope you remember that mindset, because that's the same mindset we're going to apply to this process as we talk through this hour. Let's weigh the benefit to risk throughout every one of these scenarios and let you answer that question. If the risk is greater than the benefit, should we discontinue? So following the AAPM position statement, we had just a list of other groups and societies that came out. The ACR, which is also American, well, obviously American College of Radiology, but it's also here, the US. Australia, Canada, several of the Canadian organizations, a couple more US ones, the Health Physics Society, Image Gently, which is a uh, it's a group. I guess society is the wrong word. I'm trying to think of the word. It's an organization that we focus on. Part of the Image Gently, we focus on describing best practices for imaging in kids. And then, of course, the Radiological Society of North America, RSNA, which is the major society for all radiologists here in the US, or basically North America, because it does include Canada. So these groups, all of them, came out with their own statement, and they said basically the same thing. They said, we agree with the AAPM. We also believe that we should discontinue using gonadal shielding. All right. The NCRP, which is the National Academy Society on Radiation Protection, it is the kind of foremost society on scientific analysis based on radiation protection. They came out, and after this position statement and after this publication from my colleague, Keith Strauss, when all of this happened, they came out and they did a year-long analysis. So it was a scientific analysis on the use of gonadal shielding, and then they've published their results. So this was an independent analysis, an independent survey, apart from all of the opinions in these position statements. And in the US, typically, you can write a position statement, you can write a paper, an editorial statement, you can do all that. But a lot of the things don't change. The educational models, the rules, the laws in each of the states, those things don't actually change until, as an example, our NCRP society comes out and scientifically says, yes, it's a good thing to change. So this position statement of don't use gonadal shielding came out several years ago, but the NCRP statement just came out at the end of last year. And so for the most part, we're starting to see a stronger or a more rapid shift here in the US of moving away from gonadal shielding. And it is because the NCRP came out and said the following: the risk of heritable genetic effects are now considered to be much less than previously estimated. In fact, if you look at all of the data coming out of the Hiroshima and Nagasaki patient population, and of course their progeny and their progeny's progeny, so we have several generations that have come from the survivors of those two atomic weapons, there has never been evidence of mutagenic effects passed on to their progeny. And so as time has gone on from 1950s to now in the 2020s, in this new decade, whenever we talk about risk associated to the gonads, we do not talk about risk associated to hereditable genetic effects. We only talk about risk of cancer. So when we talk about risk to gonads, we talk about the risk to the individual, not to the future generation. And then, of course, I already demonstrated this, but improvements in technology since the 1950s have resulted in up to 95% reductions in the absorbed dose to the pelvic organs from radiography. And then gonadal shielding can and often does obscure portions of the pelvic anatomy, and may obscure important findings on radiographs. This limits the practical dimensions and area of the shield. So what they're saying here is the placement of the shield is never perfect, and we'll talk about that in a moment. And because we're looking at the pelvis, especially if we're talking, say, female anatomy, where the shield is going to be central to the imaging for the ovaries, whereas, of course, it's more inferior for men when it's covering the testes. But when it's in the field of view, when it's in the image, it has the potential to cover up important anatomy that is being used by the radiologist to make their diagnosis. And because of that, over time, these shields have actually shrank so that they could minimize the collateral damage of covering up important anatomy. And therefore, they've become less and less effective with time because the shields get smaller and smaller. And most of the time, miss covering up the gonads. All right. So despite adherence to practical guidelines by technologists, gonadal shields may not completely shield the gonads in the majority of patients due to the limited area of the shield and normal variations in patient anatomy. This is especially true for women. The ovaries are not exactly in the same location every time. And obviously for men, there's variation too. And so because of the inability to standardize the location of these shields, it's become very difficult to do it correctly over time. All right. And then finally, what I will show you going forward is these organs that we're talking about, the gonads, they're inside our body. Now, I know for men, testes are, technically outside of the body, but the point here is a lot of the scatter radiation. So if you image into the abdomen, once the photons enter into it, they're going to scatter. There's a lot of scatter. We talked about this for the last couple of weeks that's why we use grids, right? The grids reduce the amount of scatter going to the detector so that we can get good image quality. But that scatter, as it enters the body and moves around, because the organs are central, or the ovaries are a little bit more central, for example, they get a lot of radiation from nearby tissue scattering into the ovaries. And the same can be true about the testes. Even though the testes technically are, outside of the body, they get a lot of scatter coming out of the body, the legs and of course the pelvis. So the point here is just because you put a shield there and that shield technically stops all of the primary radiation coming down incident on it, the radiation coming down around the shield that's not stopped will scatter, and it will scatter into these organs. All right. Another thing that they talked about that risk is gonadal shields can interfere with the use of the automatic exposure control, the AECs. And therefore, they can actually cause radiation to go up when we image with AEC. And so if you put the shield, so here these little dashed lines represent areas of where the ion chambers for the automatic exposure control systems would be located in these images. So if you had these patients on your table and you've located them such that, maybe you're looking at the female and you're looking at the inlet here of the pelvis, and you're using either the center AEC chamber or either the left or the right, if you place a shield over here, it's going to cover that AEC. It's going to cover that ion chamber. And therefore, the system is going to think it's a very, very, very dense or very, very thick patient. And so it's going to turn the MA really high. Now, the shield is covering, in theory, covering the gonads, but it's not covering the colon. It's not covering all of the other anatomy that is potentially in the field of view. And therefore, other anatomy is going to get a much higher dose. In fact, when we look at the weighting, the sensitivity, the tissue sensitivity weighting factors, these are a calculation of what we think these tissues are relative to other tissues. So this whole thing adds to one. This tells us roughly how sensitive these organs are compared to others. And so colon, as I mentioned, which is obviously present down here in the pelvis, the colon has a 12% weighting. The gonads have an 8% weighting. And I would just point out that the gonad weighting has done nothing but go down in time. And that's because it originally was a high weighting factor because we thought there was heritable effects, i.e. genetic or mutagenetic effects that would pass on to our progeny. Because that has never manifested, every time they assign a new weighting factor value, 2007 being the most recent, and so they're actually coming up due probably in the next decade for new ones, that value, that gonadal value, that 8%, 0.08, that's going down every time. But the point here is if there's red bone marrow in, say, the pelvis, and there's colon, these two things are at 12%. There's bladder here, 4%. And so there are all of these things, skin and a few other things that are in the field of view that are getting radiated too, and they actually have higher sensitivities to cancer induction than do the gonads. So using a shield can potentially be a very big negative. So let's talk about these shields. Gonadal shields are typically 0.5 millimeter of lead. So they're very effective at stopping primary radiation. So when you place the gonadal shield here on this young lady, the photons coming in incident on this are not going to pass through to the body. And that is why they look on the radiograph very white, because the shield itself absorbs almost all, if not all, 99% of the photons. And the same can be said about a man. You place the gonadal shield, the shielding on the patient anatomy, and once again, you see it's almost perfectly white. That means it's absorbing 99 to basically all of the photons. So when properly placed, yes, the shield will do a very good job of cutting down the primary photons incident on the gonads. So there was a paper that I reviewed, and that paper reviewed 18 other studies. So it's a meta-analysis of 18 studies. So they looked at over 3,000 radiographs, and they found that 85% of these 3,000 radiographs, the female shielding, the gonadal shielding for the female was mispositioned. So this is just an example from that study. You can see that it is relatively difficult to properly place it. Now that kind of makes sense, right? This is what the technologist sees. They see the female anatomy from the outside, the exterior. There are landmarks, of course, that we can use, the bony anatomy of the pelvis. Obviously, they are instructed to place this over the inlet of the pelvis. And that's in theory where the gonads are. But as you can see, jumping back to this one, that's not always the case. Now, was it just that this was maybe not done properly? Yeah, maybe some of this was a little sloppily placed. But the other comment I would make is if you look at these, the different shields, they're all different sizes, they're all different shapes, and they're all different. And so you have the potential to cover up surrounding anatomy quite extensively. Now, you might think, how can we misposition a shield for men? Their gonads are exterior to the body. There's a pretty good way of detecting where the male gonads are. We can generally visualize it. But in this meta-analysis of over 3,000 radiographs, 52% of male shielding was mispositioned. And here's just a simple example. The shielding was placed way too much inferior to the gonads, completely missed the testes. So Mispositioned shields, once again, will obscure potentially important anatomy, more specifically for female. But if the shield had been placed superior, then it potentially could have done the same thing. So let's talk about the fact that you and I and everyone in between, we're all different people. Specifically speaking, let's talk about women. In a paper here that was published in 1999, so this is a not new knowledge. This is something that we've known about for 2 decades now. Gonadal locations were observed. They used ultrasound to identify exact locations, and they looked at it from person to person, looking at the variation, and every one of these circles represents the location of the ovary. So 70 adults were looked at, 128 ovaries were positioned or identified in space, and you can see there is a considerable variation in the location of the ovaries. And so if we were to assume we could place the shield perfectly over the inlet, you would see that we are still going to miss some gonads. Now, obviously, the majority are here central, that I will not deny, but there are still quite a few that fall outside of that area. And that is assuming you can place the shield perfectly over the inlet. So the other thing we did, so this is now myself and 2 of my colleagues at Cincinnati Children's, we did a study a couple of years ago. Actually, it was just published last year, in I think December of 2020. And what we did, it was a Monte Carlo study. So we had a couple of phantoms. We had these anthropomorphic phantoms that I've talked about in the past. So they simulate different tissues in the body, bone, of course, soft tissue. And we had an adult male, well, we had an adult that was both male and female, and we had a 5-year-old and a newborn. And so in every one of these, we were able to calculate the actual dose to the ovaries and to the testes. So ovaries shown here in this orange circle, testes shown here in these yellow circles. And we did that without shielding. And here you can see the color variation. The lighter the color, whiter the color, the hotter the dose. And as the colors got darker, going from orange, blue, purple down, that's when the dose was reducing. And you can see here, obviously, the radiation dose gets much, much lower as it penetrates through the body. We talked quite a bit about that last week. In fact, the amount of photons coming out the back end is really only about 1% of those incident on the anterior surface. Now here you can see when you place the shield actually over top of or anterior to the location of both the ovaries and the testes, you can see there's the shadow, and that demonstrates that the primary beam is mostly reduced. And I know it's a small image and it's small on your screen, and please forgive me for all of you out there that are colorblind, but there is actually color in here overlaid on this gray and white CT scan of the ovaries, of the phantom. And so there is actually scattered photons coming into this area, even though the primary beam completely cuts that out. So what we did is we wanted to know what is the actual dose to these organs based on proper shield location and then improper shield location. So here I'm just demonstrating that here's the 5-year-old and here is our little newborn. So these were, of course, you can see here the anterior posterior view, and then this is just a simple sagittal view, and you can see the full field of view as imaged, and you can see it without shielding and then with shielding, how effective the shielding is at reducing the primary beam. And you can see that here for the little guy too. So what we did is we took this and we simulated a shield in place, and then we slowly moved that shield anteriorly 2 centimeters, and then we would redo the simulation, and we did that for a total of an 8 centimeter shift anterior to where ideal location should be. So what were the results? Well, the results were that we found in the adult, ovaries received about 40% of their dose from scatter. And what you can see here is the 0 here on the x-axis represents the shield in proper place. So it's ideally placed. And then we shifted it 2 centimeters, 4, 6, and 8. And that's when you're looking to the right on this axis. You can see how the overall dose reduction is reduced to the point where definitely when you're about 4 centimeters or 6 centimeters off of ideal, so mispositioned, only 4 to 6 centimeters, you can see there's basically no dose reduction at all. The shield itself is not in any way contributing, maybe 5 to 10% at most contributing to dose reduction. And the 3 colors you see here are the 3 phantoms. And then the top one here is the ovaries. And then, of course, you see here the testes at the bottom. Now, it's a little bit more gradual of a reduction here on the ovaries, and that is just because there's a lot more scatter from the abdomen itself. There is a much more distinct shift. So if you offset the shield only by 2 centimeters over the testes, you're still getting about 90% dose reduction. But you go just another 4 centimeters, you can see how it almost completely goes away. And that just demonstrates how much the shielding affects the actual dose reduction because of where the location of the testes are being outside the body. We saw that for the ovaries, once again, for kids, for pediatrics, so looking at our 5-year-old and our newborn, 30% of the dose to those ovaries come from the scatter. And here I just gave you all the numbers, but I'm not going to go over all those. Now, for the testes, for the male, the dose reduction was about 85 to 90% for adults. Properly placed shields over the testes reduce the dose by 85 to 90% for adults, and 10 to 15% of the dose from the test to the testes came from scatter. And we just kind of talked about that. So the ultimate result was that if you're basically 6 centimeters off center, off of mispositioned, you're basically cut the effectiveness of the gonadal shields to 0. And that was the same for both testes and ovaries. Basically at 6 centimeters, these basically go to 0. So gonadal shielding use does not contribute significantly to reducing the risk from exposure. And the gonadal shielding may have an unintended consequence of increasing the exposure, which we talked about using AEC. Gonadal shielding may obscure important anatomy, leading to loss of valuable diagnostic information. So that was the benefit to risk ratio that the NCRP and others, like I saw that I demonstrated in our publication, how we demonstrated that we don't see a benefit because you can't actually cut all of the radiation dose to gonads. Just no matter how many shields you put on top of the patient, you'll never reduce all of that in scatter. And the risk factor we felt is higher than the benefit. And so there is no benefit, but the risk is higher for loss of diagnostic acuity. So, we basically discussed this. Dose of the gonads has come down quite a bit over the last 7 decades. If you want, here's a website. So when you get a hold of these slides or watch this again another time, you can go to this website. The AAPM came up with an organization called CARES. It's an acronym. It's basically, if you go to this website, it gives you a whole lot of information, both scientific and other, that gives you information about gonadal shielding. So if you want to know more about this, go to this website. There's also a URL here for the NCRP. And this is a trifold. In other words, we have the CARES group created these documents and stuff that now I know they're in English, but for people here in the US, they can hand out. So if a parent or a patient walks through the door and says, "Why aren't you doing gonadal shielding anymore?" There's information that they can actually hand out and say, "Well, if you're interested, things have changed, blah, 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 blah. Here, you can read more about it." So all of that information is there. My guess is if you were interested in getting that into Thai, you could reach out to this group. I actually know the individuals that are the chairs of this group. They're wonderful ladies. They would probably be very willing and very, very willing to work with you. Okay, so we talked a little bit about gonadal shielding. We spent a lot of time on that because that was the question that Tanya had. So let's talk a little bit. At that point, I put together my slides and I thought to myself, okay, now we'll transition this to mammography. But I thought to myself, so many people once we started taking away the gonadal shields, they started asking other questions about, well, what about the other shields we place on our patients? And obviously parents have shielding because they're standing next to their kids. Why didn't we remove all of the shielding? So let's talk about all of the other stuff going on here. So when we are in the same room, when the x-ray machine is on and we're imaging, generally speaking, we, the staff and our parents and the caregivers, they will wear lead. And this is for a lot of reasons, especially in pediatrics, where they have to kind of be there. Sometimes they actually have to hold the kid in place. Other times they're there just for emotional comfort and support. So how much scatter radiation does do these kids and or adults, when they are being imaged, produce? How much scatter is coming off of these individuals, the patients, into the room? And then, of course, incident upon the staff and or parents or anyone in the room that are wearing these lead aprons. So the question is, do we need to wear these lead aprons? Is there a sufficient amount of scatter in the room? So this is a work that myself and Keith Strauss did at our institution. We took our anthropomorphic phantoms. Once again, we have the adult, the 5-year-old, and the newborn. So we're just kind of testing this across different body sizes. And we measured the amount of scatter coming off of a head, a chest, and an abdomen/pelvis when you're doing a radiograph. We also used, because these phantoms, as you may recall, they don't actually have extremities. So we had to use just some really simple PMMA blocks to simulate the extremity. And we've talked quite a bit about using those in fluoroscopy and radiography. And I've talked about how very versatile they are. You don't necessarily need these crazy expensive anthropomorphic phantoms. If you just had if you just stacked up these PMMA blocks, you could do this exact same experiment for yourself if you're interested. And what we did is we exposed these phantoms. We used the standard clinical protocols. Therefore, we did not modify in any way the KV, the MA, and we actually had some technologists come in and help us set the field of view as if it was an actual patient. So here's the example. This is the 5-year-old phantom where they set the field of view. You can see the light field being projected on it. You can see the marker there for the centering, for the head, the chest, and the abdomen pelvis. And here you can see our ion chamber at the end of this table. We measured perpendicular, we measured parallel, so kind of at its foot. And then we also made some measurements right at the point where the photons would be coming into the patient. And we made all of these measurements so that we could get a feel for how much scatter was coming in as a function of the amount of photons or radiation incident on the patient for imaging purposes. Now we placed the ion chamber all the way out here because we actually needed the photons to be coming in parallel. If you got it closer, there's a divergence, and so it changes the imaging paradigm. That said, we imaged out 100 centimeters, and then we used the inverse square law to correct to 25 centimeters. In other words, all of the data I'm going to show you is with reference to 25 centimeters, which is about where you, if you were a staff member or you a parent or a caregiver or someone, were standing if you were helping, say, hold a patient, or if you were just sitting there talking to them, helping them stay still. All right. So here are the results from this. So this looks at the percent stray radiation measured at 100 centimeters from the X-ray beam compared to the radiation that's going into the phantom, or in our case, the patient, a patient. For the newborn, a 5-year-old, adult. Now, for the skull, abdomen, thorax, forearm, you can see the highest amount of scatter coming off of any of this is for the adult, which would make sense. It's bigger, so it produces more scatter. And we're talking about 0.3%. That's the highest amount. So when you look at the total amount of photons going into the patient, only 0.3% of them are coming off the patient or out of the patient. So the amount of scatter is actually pretty darn low. So what does that mean? In the US, we have a law that says if you're in the hospital and you're around X-ray equipment, a member of the public, so not a worker, but a member of the public, can only receive up to 1 millisievert per year of radiation exposure. So if that is the absolute limit that they can be exposed to, how many procedures could they, in theory, stand next to? So how many times, if you had a patient, let's say you're a mom or a dad and you have a 5-year-old child, how many times could they go into a room, stand 25 centimeters away, so right next to the patient, during a skull or some imaging in the head, abdomen, thorax, or forearm? And that's what these numbers represent. So in that example of a 5-year-old getting, say, an abdomen, one view abdomen x-ray, they could, in theory, stand next to this patient 95 times and never exceed this number. So they would not actually be breaking any laws up to all of these numbers. So for a newborn, which is probably where most parents are physically at the side of the table helping the patient hold still, because they're literally holding their arms down or holding their legs down because the kid's trying to get away. You can see that we're talking about nearly 1,000 times. And to my knowledge, I have never seen a patient get 1,000 abdomen exposure x-rays in 1 year. I don't think it's ever happened. Now, this, of course, is all just x-ray, just plain our radiograph. And if they're helping an adult, because, we do have to help. Some adults may have maybe like Down syndrome, or they have other developmental issues, so that adults might have to be in a room with an adult to help that patient get imaged. We're still talking that maybe potentially they could be there for 18 abdomen x-rays and not exceed this number. Now, what about you and me as a staff member, as someone that we carry our badge, we got our radiation badge, we got it clipped onto our collar, we got it onto our lanyard or whatever when we're walking around the hospital. Now, in the US, once again, forgive me, I don't know what the laws are or the rules are in Thailand, but in the US, as a radiation worker, someone that carries a badge, I'm allowed to receive 5 millisieverts per year. Now, we also have a rule that says if you're going to exceed 10% of that, if you're going to, so 10% of that value, so 0.5, if you exceed 10% of that value, you need to have a badge on. If you are a staff member, so you work in the hospital, but you will not exceed 10%, you actually don't have to wear a badge. So that's why some people will go into radiology, they will work in the area like a nurse or something, and they aren't badged. That's just how we do it here in the US. So the question is, once again, how many procedures could they help out with and not actually need to wear shielding or wear a badge? So they would be completely legal to be exposed these many times without breaking any rules. And here you can see that the number is much lower, of course, because we're talking only 10% of this value, so 0.5 millisieverts per year. You can see now for a 5-year-old, it's only a couple. For adult, it's less than 1. But for a newborn, which is generally speaking when like a nurse or someone needs to help out in the x-ray room, we're still talking numbers like around 20 or so, maybe 80 thorax chests. So the point here is the amount of scatter coming off of the patient when they are being imaged in an x-ray room, so we're talking DRCR imaging, it is very, very low. And so technically, the parents that when they walk into the room don't necessarily need lead per certain rules and laws in our country. And technically, the staff could probably get away without it too. That said, I need to just say this, in the US, we have a law that says if you're in the room, you have to wear lead shielding. It's quite literally written in as a law. And so even though we did this study and we did all these calculations, we did this to demonstrate that this law is really unnecessary. And maybe in the future, it'll go away. It would be simpler that when a parent walks in, they don't have to don all of this lead. It tends to make people scared. And then obviously you have to clean it off. And in an era of COVID where everything has to be highly sanitized, this would just be one less thing that the technologists have to deal with every time a parent or a caregiver walks into the room to help a patient get an x-ray. One thing we have noticed as we've talked a lot about fear of radiation, people that don't understand radiation, they fear it, of course. And so when you walk in the room and you already are afraid of radiation, and then we ask them to cover themselves in lead, it perpetuates this fear that the x-ray that this procedure, this exam that we're about to perform on one of their kids or, someone else, it could be an adult, it's perpetuating this idea that it's very unsafe. And we know in radiology that of all of the imaging that we do, x-ray imaging is probably one of the least risky. It's so low dose, so low dose. And so we want to try to get away from us as radiologists, as people working with radiation, perpetuating a misunderstanding of radiation. Now, I'm not trying to say that all radiation is safe. I'm just trying to say that for what's happening in radiology, generally speaking, that benefit is so much higher than the risk that we do consider it okay for this type of exposure. And we just don't want people to have that fear, because it really does prevent, in sometimes in real cases, I've dealt with this in our hospital where parents will not let their kids get x-rayed because they are afraid of radiation. But we're talking about such low amount of radiation that the benefit is so much better than the risk. All right, so let's keep going. The next thing that you see is, for example, you're doing a chest radiograph. We will oftentimes strap some kind of shield around, say, their pelvis. We will place shielding outside of the field of view. So in this case, this young little girl is getting a chest radiograph, a lateral radiograph right here. This shield, there's no light. There's no light on the shield. That means the system is collimated to above the shield. The shield is not stopping any primary radiation. There is no primary radiation incident on that shield. So we're going to talk about, is that type of shielding necessary? All right, so out of field exposures, only scatter radiation is incident on organs outside of the field of view. We've already talked about this, right? This idea that if you're imaging the chest, the radiation affects the dose that we're giving to our abdomen organs, that's coming from inside our body. That's the scatter in our body. It has nothing to do with the radiation incident upon or striking our body. So there was a lot of work on this many years ago, and this was mostly calculated for dose to the conceptus or a fetus. So if we're going in and we're doing, say, a chest radiograph, let's say a 2-view radiograph of the chest, how much radiation dose from that exposure would be incident down into the pelvis onto, say, a fetus if a woman was pregnant. So we found, and doing, not we, but the greater scientific community found that the organ doses outside of the field of view, the direct imaging field of view, those organ doses depend strongly on the area of the imaging field of view and the distance from that field of view. So let's take this PA chest radiograph that we're doing here. You see in this infographic, the photons are incident upon the back, the PA, the posterior to anterior aspect of this image. We're imaging the chest. Now, like I said, this was developed back in the day when they were looking at conceptus dose. So here you see the uterus, but any organ down here in the pelvis, gonads, whatnot, or colon, stomach, anything down here in the abdomen can also be calculated using this equation that I'm about to describe. And so we're going to talk about the area of the imaging and the distance from the edge of the field to the organ. This is the edge field distance, EFD. So when you look at this equation, it's a very simple equation. We take the entrance skin dose that we can calculate here, and we've already gone over those calculations many a times the last couple of weeks. I'm not going to go over them again. And if you multiply it by this EFD correction factor, that will tell you how much the dose is to these internal organs. So let's just look at this. So I know it says depth of conceptus, because like I said, this is developed for pregnant women. But this could be the exact same thing if you're looking at, say, the colon. the bladder, even the small intestines, or anything outside the field of view. We could be doing an abdomen here, and we could be looking at the dose to the breast or the heart or the lungs. It's all a matter of distance, whichever direction we're looking. So if you look at something that is, say, 10 centimeters from the field of view, the edge of the field, so 10 centimeters down from this top red line, if the organ is roughly 5 or maybe even 10 centimeters deep in the body, so somewhere midline to the body, we're talking about only 2% of the entrance skin dose. So the dose of these organs is only 2% of what the skin is receiving out here. Now it gets a little higher if we get closer, so 2.5 centimeters from the field of view. So if you're looking at maybe the transverse colon up here or the stomach, then of course the percentage is a little higher. Talk about 10%. But these are still low percentages in general. So rule of thumb, if your distance from the most inferior portion of the imaging field of view is greater than 10 centimeters, generally speaking, it's 2% of the entrance skin dose. If you're greater than 25 centimeters away from the inferior aspect of this field of view, then the dose is negligible. The dose to that organ is, you just basically couldn't measure it. So do we need to place shields kind of on the outside? So if we came in here, we're doing this PA chest radiograph, oftentimes people will place a lead apron back here covering the pelvis and the abdomen of this patient. That is not in any way stopping any form of radiation. It is quite literally doing nothing because all of the dose to those organs is coming from scatter. So are there other types of imaging, out of field imaging? The answer is yes. Let's think about dental. We oftentimes will drape our patients in these lead aprons. We might even strap a thyroid shield on their head. And then we'll take the intraoral x-ray tube and we'll place this lady's either going to have a digital, you can see it's a cord coming out. So it's a digital film or, just regular film. And you can see how it's pointing at her mouth, not down at her body. And so once again, the photons that are going to be incident on her body in this image, in this picture, are scatter. So when you look at the various different organizations in Australia, UK, the US, the European organizations, all of these groups all agree that there is no justification for the routine use of lead aprons in dental intraoral imaging. It's just, once again, that distance from the field of view down to any kind of organ down here, we're talking more than 10 centimeters, almost always more than 25 centimeters. If we're talking breast, chest, lung, abdomen, even gonads. Gonads are just, we're talking almost a meter away from the mouth. There is no scatter down there. And so unless you're pointing that intraoral tube down at the body, there is no primary radiation going down into the body. So that's the same also for thyroid shields. Even though the thyroid is that much closer to the mouth or, to the actual intraoral or the cavity of the mouth, the fact of the matter is you can reduce the dose from the scatter to the thyroid and any other organ in our body more effectively by using fast speed film, ERF, or using new digital detectors, because you can reduce the MA really low with these new faster films and digital plates that we can place inside the mouth, using usually a fraction, sometimes a tenth of the radiation dose that we have done in the past. And so therefore you can place a thyroid shield over the patient, but once again, it's just dose coming down from the scatter. So the thyroid shield is not preventing anything because thyroid shields only prevent radiation that's hitting it from the outside. It's not preventing anything from coming down into the body. And so you will save more dose of the thyroid by using new technology and collimation. Now I know you can see here in these images, there is no collimation. That's a circular collimator. That's a circular orifice. That is the vast majority of what intraoral imaging, the imaging in intraoral dental we use today. That said, from the 1950s forward, the various different dental organizations have been recommending using using longer PIDs, these position indicating cones, and they've been recommended using square collimators. The film in dentistry is always rectangular. It's never circular. It's always rectangular. And so that's the whole concept of this collimator. If you can do a good job of matching it up so that you're not getting film cuts, but the radiation is actually going through the square collimator, the rectangular collimator, into a rectangular detector, you're reducing patient dose and you're reducing the field of view. So therefore, you're reducing the amount of scatter coming out of the mouth into the rest of the body. So we've talked about internal. Once again, these shields do not prevent against internal radiation. Definitely, there's no gonadal issues. And every one of these organizations said that it's pointless also for pregnancy. And that's just because, I mean, looking at this, if this young lady here was pregnant, I mean, her fetus would be down here. And the amount of scatter from here to there would be negligible. So you just don't need to do it for pregnancy purposes. What about other types of imaging in the dental clinic? Well, we have panoramic or cone beam CT. So now we got the system where the tube will actually spin around the patient. Once again, there is no evidence supporting routine use of lead because once again, the photons are aiming at the mouth, at the face, not down at the body. In fact, there is a potential for negative. If you go out in the literature, there's enough publications out there to justify this. But sometimes when people place the thyroid shield on the patient, that thyroid shield can actually infringe upon the imaging, especially in the jawline down here. And so there, when you look at the newest guidelines when it comes to doing panoramic and cone beam CT, they recommend not using thyroid shields. Because if this happened, and for whatever reason they need to see this, you're going to have to image this patient again. Not only did you not save this patient dose, you doubled their dose. And I just have to point out this wonderful picture of this young lady wearing a lead apron and a thyroid shield. That thyroid shield is not covering her thyroid. And so how many times do we give our patients shielding, but we don't take the time to help them put it on properly? So first of all, the shield's not doing anything anyway. But second of all, it's definitely not doing anything when it's not being worn properly. Now, what about cephalometric imaging? This is the one exception. I told you there's an exception to everything. So here's an exception. In cephalometric imaging, of course, the patient, so we're looking at it laterally, the scanner transitions, so the scanner detector goes along the side of the patient like this. It just scans along and we get a nice lateral projection of the face. In that case, because the tube is always constantly pushing radiation one direction, if you put a blocker around the thyroid, in this case also the cranium, you are going to reduce dose to those organs. Now, as long as these shields in no way infringe upon the diagnostic quality of the image, in other words, not covering up anatomy that you need to see, then those shields are actually preventing dose to those organs. So in this case, sure, use it if you want, but you got to be good at setting it up. Because if you missed it, that say you're using this cranium shield and it comes down, if it's too low, too high, or whatever, and same thing with this thyroid shield, if it's too high, you're going to infringe upon imaging. Now, I would make the argument that once again, dental imaging is incredibly low dose. And the cephalometric imaging is relatively speaking rare compared to intraoral or even panoramic or cone beam. We just don't do as much cephalometric imaging. Therefore, the dose to the risk to a population to those people in the Thai, the Thai population that come in to get this imaging is pretty darn low. All right, still talking out of field imaging. So now let's talk mammography. Now, there was about 10 years ago here in the US, we had one of those medical doctors that is a talk show host. So it's a he in this case. He went on and he has a talk show every afternoon and he goes on and he gives medical advice to everyone. And for whatever genius reason, he said, hey, if you're going to go get a mammogram, you should wear a thyroid shield. He made that statement. And then overnight, all of these women going in to get mammograms immediately started demanding thyroid shields. And so various different organizations, but mostly the society, for example, Society of Breast Imaging, the people that deal with imaging and mammography every day, they had to finally come out and say, listen. You do not need to use a shield on the thyroid because of the amount of radiation incident upon the thyroid. They did scientific studies. They looked at this. The only type of radiation that's incident on the thyroid from mammogram is radiation that's coming from the X-ray tube. Because obviously, when the lady comes in and she's on the machine, so she's got her breast in position, her face, her thyroid is right up here next to the top of the machine. That's actually where the X-ray tube is. So there is a potential for X-ray radiation or leakage to come out of the X-ray tube and be incident upon her face or her thyroid. And so when they looked at that, they found that there was only about 0.005 milligray that was incident upon thyroid. That is equivalent to 30 minutes of natural background radiation here in the US. Now, I know natural background radiation is much lower in Thailand, so it would be a little bit more for your population, relatively speaking. The point is that thyroid shield is just unnecessary. And in the off chance, the small chance that that thyroid shield would infringe upon the imaging, it would be a negative. So generally speaking, the thyroid cancer risk, the risk from imaging using a thyroid shield is greater because it could actually infringe upon the imaging. The minimal effect from the amount of radiation that you're actually reducing using this thyroid shield, it just doesn't really warrant the use of it. And then the other thing that this publication in this society talked about was the fact that most mammograms are being done for women that are between 40 and 80 years old. Now, I know some younger women can get it if they have higher risk factors for breast cancer. And so their risk of cancer from thyroid will go up with age. It goes up with younger age. But when you get to the 40s and the 80s, your risk of thyroid cancer is really low. Less than 1 in 17 million patients will get cancer from thyroid. Will get thyroid cancer. So you can prevent 0.005 milligrams of radiation on the thyroid using this shield. But to what effect? If that photons did go in and did actually irradiate the thyroid, you only still stand a 1 in 17 million chance that photon could actually even potentially cause cancer. So it's the risk factors are so low. And therefore, all of the various different organizations, the ACR here in the US and the Society for Breast Imaging, all of these societies came out and said, no, you do not need to wear a shield for a thyroid shield when you're doing mammograms. So let's just do a quick review of all of these. So once again, we talked about how internal organs receive scatter from radiation dose when it's not. Internal organ dose is from scatter radiation, not directly irradiated. And this is all based on the distance from the edge of this imaging field of view, that light, to whatever organ you're considering. And we've known this, as I said, for a long time, since the 1960s. So out of field of view organ doses are negligible for both X-ray, so DRCR, dental, mammo. What about CT? So let's just briefly talk about this. This practice has basically gone out of vogue, but for a long time, for probably about 5 years ago, this was pretty routine. And it was primarily for breast shields and eyes, and shielding the eyes for eye lens. And these shields came in all shapes, forms. It just depended on how and what your organization, your hospital used. So what happens? Well, what's going on? So first of all, these shields are usually made out of bismuth, so they're called bismuth shields, not technically lead. And then if you would just place them directly over the eyes, or you'd place them over the chest. Whatever age, obviously this is a phantom, so it's a young phantom, so there's no actual breast anatomy being demonstrated in that image. So let's talk. Do these shields do anything to reduce the dose? Yes, breast doses can be reduced 85 to 90% when you place these bismuth shields over top of the chest during CT of the chest. And then eye lens, the dose to the eye lens will go down by about 35% when you're actually directly scanning or doing a CT scan that covers the eyes. But do they affect image quality? And the answer is yes. Breast shields have been shown to reduce the contrast to noise ratio and the CT number accuracy in the region but beneath or underneath the shield. Eye shields will increase noise to the globe of the eye by about 23%. So in general, most of the publications that came out about like I said, about a decade ago, they said that, okay, yes, the dose can go down, but the fact that these shields can increase or decrease image quality, that benefit to risk ratio is out of control. It is improper. Because if the benefit was always at the dose reduction, then yeah, I would still use them. But if the fact that there's a risk that the images that we give the radiologist are undiagnostic, well, what are you going to do? You have to re-image the patient, but without the breast shield this time. So now you've doubled their dose. You may have lowered the breast dose for a little bit, but you've increased the dose to everything else twice. Are there better ways to reduce dose in CT? The answer is yes. And a publication came out from Wang and some of his colleagues there at Stanford University. They looked at just standard chest CT of this, excuse me, this is eye and this is the chest. So the blue is just a standard, no shields, just normal imaging technique. And then the red is if you actually place the bismuth shield in place. And then there is the green, which allows for organ-based tube current modulation. And we talked about this, how some CT vendors will actually, as the CT scanner comes across anterior to the body, over the eyes or the breast, or even the thyroid in some cases, it will reduce the MA over the anterior sweep, and then it'll go back to normal as it spins around the body. And there is one vendor that will reduce the MA and actually increase the MA as it goes behind. Point is, organ dose modulation will reduce the MA to the anterior organs, be it the eye lens. It was developed also for thyroid, but specifically to what we're talking about, the breast and the eyes. So you can see here, the organ dose modulation, this green value, was basically equivalent to the dose reduction that we saw with bismuth shielding. You could also just simply use a lower MA imaging technique and match it. So the point here is you can actually get good dose reduction for these critical organs without using the shield itself. Here you can see that we learned when they started using these shields that you can't actually place the shield directly on the face. You have to put pads underneath it because you get this change in CT numbers and you get this artifacting right behind the shield. Here you can see image quality. This is a phantom, no shielding, standard imaging, but now organ dose modulation. So the MA is reduced here anteriorly. And then just if you dial in a lower MA, the overall image quality, I would argue, here in the globes are the same. If anything, it's actually a negative when you put the bismuth shield on. And the same can be shown for the chest. All right, so in general, setting up a proper CT protocol is as effective as using bismuth shields. Using modern tube current modulation will give you good dose reduction without artifacts, without change in CT numbers, and without increased noise. So the modern scanners that we have, X-ray, dental, mammography, although we're not really talking about that, I guess, as much, and CT, they are so much lower dose now, and the technology that we have provides us a lot of tools to reduce the dose to critical organs, be they, the gonads, be they eye, lens, breast tissue, thyroid. So we can use this new technology to reduce the dose in these areas instead of dealing with all of the various different lead or bismuth type shields. And once again, these types of shields that we place outside, exterior to our body, only prevent radiation when the radiation directly strikes those shields. It does nothing, these shields do nothing to reduce internal dose to the organs from scatter. So the question that we always have to ask ourselves is the shielding being effective or ineffective? So if it's ineffective, we could easily say, yeah, which we don't need to use it, right? If it's ineffective and harmless, yeah, maybe we could use it if the patient absolutely wants it because they are scared, they're worried, and it makes them feel better knowing that they have a lap apron on when you're doing a chest radiograph. That's okay. If that makes them feel good, and it's not infringing upon the image quality, go for it. It reduces anxiety. That's a good thing. So I meant to forget to mention this. In our institution, we are largely moving away from using a lot of these out of field shielding. We're definitely moved away from using gonadal shielding. One day we'd love to stop handing out lead to all the patients that walk into our room, but until the laws change in our state and our country, that will persist. The point here is when a patient asks, we do give them lead. We're not we're not trying to cut them off cold turkey here, but we do counsel them and we do instruct them and we give them information so that they can take home and read, trying to help them understand that they shouldn't be necessarily afraid of radiation, especially in medical imaging. All right, so I went a couple minutes over, but this was meant to be a very comprehensive review of overall shielding. And so if you have any questions, I'd love to try to answer them.
Wow, thank you so much, Sam. This is really practical for us. And it's like a daily practice thing that we usually get the questions from the patients and we among ourselves, like, oh, should we like shield the patient or not? So final answer from you is we don't need to shield the patient. And even
Technically, no.
Yeah, and even like this is like a for radiograph, and even for like a parents that come into the room to help with the patient stuff, we don't even need to shield at all.
Well, so the answer is no, it's not really necessary, but you know, where you work, yes, you have to because it's a law. I don't know what the laws are in Thailand, for example, where you may not have a physical law that says anyone in an x-ray room has to wear shielding. If that law does not exist, then that's something that I would encourage the radiologists, the medical physicists, and your technologists to talk about. Is it necessary? I always encourage you guys to take the results. You can go back and look at my references and our publications. We've done a lot of this work. There's others out there that are published on this. So, I encourage you to make your own decision and you can try to replicate our results. But in the end, like I said from the very, very beginning, I truly believe these types of shieldings are ineffective.
Yeah. So this is like for the patient who come to get a scan, right? But in case that the patient come for the CT and she does not know that she's pregnant, let's say like we did a scalp view and we don't really know because like a fetus is very small. So in that case, maybe we scan like a one face already and technology just, oh, okay, that is a fetus. I should stop. I cannot do anything more. So what is like the practical point or what should we do? Because right now, Napapong is the one that we get contact. Like, okay, call Napapong, ask for his help and those things. Yep.
Yeah. And so, there are times where we actually will image a pregnant woman. We will, let's say we're imaging her head. We just had in our institution a couple months ago, we had a young lady that was pregnant, but she needed her head imaged. There was no question in our mind. We went forward. We did the CT of her brain. The amount of scatter coming from here down to here is almost negligible. I actually did the calculations. We also actually imaged her abdomen because we needed to, for her health, the benefit to the mother was we needed those images. And now she wasn't real far along, and she was actually a tiny little girl. So the amount of radiation that the system used was really low. In our case, it ended up being less than 10 milligray to the fetus. And 10 milligray is, when you look at the guidelines here in the US for imaging and exposing a fetus to radiation, anything less than 50 milligray is just negligible. It's just no risk. There is a gray area between 50 to 100, but there's never been medical evidence showing that if you did image and you exposed a fetus to say 70 milligray, there's no real direct evidence that there would be some problems with that. After 100, yes, we do know, and that's based off of Hiroshima and Nagasaki. We know high levels of radiation incident on a fetus in utero can, excuse me, have some effects. There can be IQ deficits, there can be microcephaly, there can be a few other things, but that's
Mm-hmm.
really, really high dose. Today in radiology, we just don't image that high. And when you go in and even a large patient can get an abdominal image and or CT of the abdomen or pelvis, and they'll get a CTDI vol value of somewhere in the 10, 15 milligray range. That when you actually take that value and then use it to calculate the dose to the organs, it's much lower. Obviously, remember, CTDI vol is not patient dose. But the
Mm-hmm.
point here is, if it's medically necessary, then the amount of radiation we're using is always it's low, and so most likely there's not going to be an issue. Now, do you want to go in and do a 3-phase abdomen study when the lady's pregnant? Probably not, because that is probably a lot more radiation that you really should use.
Mm-hmm.
But if you're doing like a chest CT or a head where it's completely out of field of view, then you could go in and you could lay an apron over her belly, but it won't do anything
Mm-hmm.
because the radiation is coming down from her head, down through her chest, into her abdomen.
Mm-hmm.
And so there is literally nothing we can do to help them to stop the radiation. So when we image for a pregnant woman, we talked about this actually a couple of weeks ago. There are techniques we can to lower the MA, to lower the exposure. We can use those organ dose modulation techniques if we have to, which reduces the dose anterior. So that's obviously where the baby is. So there's ways for us to do this to reduce the potential for risk. And that can be said about an x-ray. If you're going in, digital radiograph. This actually happened to my wife when we were first pregnant with our first child. She got in a car wreck and she got real bad whiplash. So they went in to give her an X-ray of her neck, and so she said, "Oh, I'm pregnant." And when they did that, so they went in to set her up. They're like, "Oh, she's pregnant," and they put, I think, 3 lead aprons on top of her belly. And
Really?
she told me afterwards it hurt more to stand there with her neck hurting from a car wreck with all this weight pulling her forward, and she was being forced to stand back and hold her neck upright.
Uh-huh.
But all of that lead did nothing to prevent the photons from hitting my kid. So
Uh-huh.
it's so, you know what I mean? It's just like we have to just think about this logically. And so as technologists, you in that room, you are the first people to think about that. And if you know that you're imaging up here or up here, and the baby or whatever we're talking about is down there, you just know that there is really no risk to that. And so we can, in that case, I wish what would have happened was the technologist would have said, "Oh, congratulations, you're pregnant, but we're going to image up here, so you don't have to worry. There's not going to be any radiation down here."
They should call you, maybe like maybe she should hand the phone.
Yeah, sure. I can just be on call all day, every day. I might have to learn how to speak Thai though, if I'm going to help you.
Yeah. So, and one thing that I just learned today is about you have many type of the shielding, like the bismuth and maybe like the lead apron that we normally use. So, which means if we need to use it, it's like it depends on the body part, or is it depends on the study, the scan, like a CT and radiograph to
Yeah.
choose a.
So yeah, we've been um, the majority are lead. Gonadal shields are lead. Most of what we use in X-ray, and DRCR and radiography, it's actually not lead. It's actually plastic that's impregnated with lead, and that's why you can fold it and move it and bend it. Regular lead would bend and break in half, but it's lead equivalent. And it's just, it comes in all different shapes and sizes, and so it's specific to the use. You saw that one image of breast shield where they actually had it come over the chest, and it just covered the 2 locations of the breast, where there was another one that laid strapped across. So they all come in different shapes and sizes, and you know
So it does have different.
yeah,
I mean,
there's really no difference in what it's doing.
mhm,
If the shield is in place, so we've got a bismuth breast shield in place, we're doing a chest CT. Every time the CT scanner goes across anterior to those breasts underneath that shield, they're getting very, very little radiation. That is a fact. That is true. But when it spins around and shooting up through the body, guess what? You're exposing the breasts because you don't have shields back here. If you wrap the patient in lead, guess what? You're not going to image anything there. And so, what are you trying to do as a radiologist? You're trying to see. Now, maybe you're not looking at the breast tissue in a chest CT. Maybe you're looking at, of course, the lungs, the lung parenchyma, the mediastinal soft tissue. But we have to image through the breast. And so, we just have to do our best to reduce the dose to the critical organs and just keep going forward. And I'll say this 1,000 times more. The technology we have now is so good. It really does reduce the dose. Now, I know there are places in this world, and I know there are places here in the US that they just can't afford fancy new CT scanners. They're using scanners from 10, maybe even 15 years ago. It's harder to believe that, but that's just what they've got. You can still do stuff with those type of scanners. You can still reduce the dose. You're limited, you definitely are. But as you keep new scanners in your hospital, so if you replace them, say, every 10 years or whatever, you're going to have new technology to do amazing things to reduce the dose to our patients.
Yeah. So lucky us, in Thailand, we don't have Dr. Oz show who can tell about that. Right? About like the thyroid shield for the mammogram. So but come back to the questions here. So how do you educate the patients or the population to know about the gonadal shield is no longer needed?
Yeah. So like I said, one thing you can do is go to these websites that I write around. Where did I put those websites?
Like the website things and just like a hand information.
Yeah. So at our institution, at our hospital, I wrote basically just a one page. It's a 2-sided page. It's a trifold document that we just hand out. The other thing I do is I have my business card. Every technologist has my business card. And if a parent walks in and it has a question, we teach our technologists. I have a spread, I have a PowerPoint. I go through all the kind of the same things we talk about here. I give them information because 99% of the time, if a parent says, I'm concerned, and the technologist is able to answer their question, everything's fine. And technologists are wonderful. They're wonderful people because they can answer these questions. But in the case that sometimes they're just freaked out, and parents can get that way, especially in pediatric imaging, I just tell them to hand my card. And then they call me. And so I get to talk. I actually just talked to a mother a couple days ago because she was so worried because her daughter has had, I think, something like 20 x-rays. And over the course of this little girl's life, she's needed those for her medical care. But, when I explained to her that, a single chest radiograph is just less than a day's worth of natural radiation, she's like, really? That's it? I'm like, yeah, that's it. We're not asking for a lot here. We're just asking just for a little bit of radiation so our radiologist can make sure everything's okay with your kid. So the answer is I would write something up, have that available. You can either put it in like your waiting room. So when everyone's waiting to go in, there'll be a little sign on the wall that says, information about whatever, shielding or radiation. And then they can just take it if they want, or you have it in the room. So if they ask a question, you can say, here you go, read this. 9 times out of 10, if they have a question and you answer it and they still are worried, even if we give them papers and we give them my business card, they'll go home and they'll never call. It's because at the moment they were worried. But once they left, the stress of being in the hospital went away. They realized, okay, I'm okay. Wherever they went to the hospital, they left, they got maybe medicine, they got treated. And so their concerns went away. And so we just have to deal with the stress in the moment. So information's good, but probably the best tool is a good technologist or radiologist, because sometimes radiologists get called in to talk to them, but a good way to just talk to them and help them calm their nerves and help them understand that what's going to happen, this procedure, this exam is for these reasons, and it's a good thing to help us understand how to help you. And when patients and parents and kids and whatever hear that, most of the time they calm down. And okay.
Yeah.
So learn to verbally communicate. And if
Mm-hmm.
that doesn't work, also have something to physically hand out.
Like a to-go person that they can contact and get the all information. Mhm. Yes,
Yep.
sounds good to me. So come to the last question. I think like you may already answer this one already. So how about using a lead apron in the conventional radiology?
So a lead apron for a patient. So when I was talking about a couple of things going on here. So there's the lead apron that we place on our patient, the gonadal shielding or the out of field of view. Usually we place it on the lap apron or the pelvic apron. Those aprons really don't really do much. As long as the radiation beam, the light field, the radiation beam is not striking where the shield is, the shield is not stopping radiation. But here you see in this image, you see this dad back here, or I assume he's a dad, and this mom back here. They're wearing these lead aprons, thyroid shield, lead apron. It's a half body, typical lead apron that you and I, as a staff member, wear. And you can see this mom. She's standing here next to her daughter, probably there for moral support to help her. Okay, stand still, hold still, take a deep breath. She's probably there helping the technologist to get a good image. You see where she's standing, she's probably about 25 centimeters away from this girl. And so based on the research that we've done, I would say that she does not need to wear that. Now, if she asks to wear that, of course I would let her wear that. But technically, I don't think she needs to wear it. Just the amount of photons bouncing off this little girl and hitting her are really, really, really low. Remember, we're talking less than 0.3% of these photons that go into this child for imaging. Less than a percent of those are coming out and striking mom standing next to her. So, is it hurting anything? No, it's not. So if mom wants it, go ahead, let her wear it. But in most cases, then, especially during COVID, you're going to have to sanitize that lead apron. You're going to have to put it away. And so obviously it's a cost. You have to pay for all of those. And here in the US, every year we have to survey. We actually have to we have to take every one of our lead aprons and run them under our fluoroscope to make sure there's no cracks or holes in them. It's required by law. And we have literally thousands of lead aprons. It's the worst job in the world to have to track them all down, review them, tag them, and do it again next year. So, if we could get away from using those, I wouldn't lose any sleep.
But for the interventional radiology, we need to wear an apron for sure. That is a different story.
100%. Yes, please. I just want to say once again, I'm talking DR in this example right here, DRCR imaging. If you are in fluoroscopy, general fluoroscopy, you're in the emergency room with C-arms, portable C-arms, you're in the interventional suite, cath lab, if you are standing at the side of the patient at the table, you should have your lead on because you are being exposed every day to radiation. And we don't need you to have any issues. So as a staff member, yes, in those cases.
Wow. There is a lot of questions coming right now.
Yeah, sure.
Yeah. So one thing, how do you think about the collimator breath effectiveness, especially for the high KV technique?
Yeah.
And another question is about the bone marrow shielding. Is there any bone marrow shielding?
Great question. So I'll answer the first one.
Mm-hmm.
Those collimators. So when you see this light field right here, every machine, when you look at the light field, the way the light comes out of these machines, it tells you exactly where the radiation is going to be. The system is not allowed to have radiation come outside of that light field. So anywhere outside of that light field, you're allowed technically up to 2% of the distance, the source to image distance. In other words, if you're 100 centimeters away, you would be allowed a couple of millimeters over. So we're talking just an itty bitty tiny bit that could come off. In my practical experience, having tested these machines for my career, where you see the light is where you get the radiation. There may be just a little bit that'll come out on the sides of it, but it's very, very, very small. And so one of the things I do as a medical physicist is I'm always double checking that the radiation it matches the light field. And so that's because for two reasons. One, the technologist needs to know if they center the light field, then when they pull the trigger, the anatomy is going to be there. If the light field is not centered, if it's mispositioned, then you'd get clipping in the image. And then the radiologist would go, and they'd have to reshoot the image. But the collimator blades are very, very good, especially at high. If 125 kV, you'll probably never go higher than that. But at 125 kV and down, it's stopping 99% of all the photons. More than that, there is where there is no light, there are no X-rays. Now, there could be a little bit of scatter and a little bit of photons coming off, but that's happening all the way up here. It's happening high off the patient. And so those photons almost always just go scattering off into the room, and they're really, really small amounts. So going to the second question about what can we do about bone marrow, there's really nothing we can do about bone marrow. Bone marrow, of course, is distributed through our body. So that's actually the saving grace. As we age, it changes position. So little kids have a lot in their skull, for example, and that's why risk might be a little higher for doing lots of head imaging versus arms. But then as we get older, it shifts into our spine and our pelvis, and it just changes location. And we just have to be understanding of that, right? Depending on the age, where the bone marrow distribution is, we can try to adjust our doses appropriately. And so I'm always very conscious about keeping doses low to our really little kid head CT scans, just because that's where most of their bone marrow is. But no, there is nothing we can do to shield about it. So we shield by using good techniques. And I would say one comment about the collimators. There have been many a times where I've been in and I get a phone call and the technologist says the mom will not let us do an X-ray. And I'm like, okay, let me talk to her. And she's like, I want my kid covered in lead. They quite literally want them head to toe covered in lead because they are afraid of radiation. And I
Okay.
simply explain to them, say, you know what? We actually put all of the shielding in our machine. So we don't have to wear. And then we walk in and we turn the light on. And I explain that to them. I says, see that where that light is? That's where the radiation is going to be. And that is what we need to make an image. And we're not going to use any more. But and then I point to outside of the light field and I say, you see how there's no light here? There will not be any radiation here. So we could place a piece of lead here or, an apron here, but it's not necessary. And I've actually done that many times. And most of the time the parent goes, really? Oh, okay. I didn't know the shielding was in the machine. And so explaining collimators and explaining lights actually is a very good way to explain to them why we don't need to be afraid of radiation going all over the patient.
Wow. That's good. Thank you so much, Sam, for explanation.